Hello and welcome to the UB Medicine podcast. I'm Dr. Allison Brashear, the Dean of the Jacobs School of Medicine and Biomedical Sciences and the Vice President for Health Sciences at the University at Buffalo. Today we're discussing a critically important topic, addiction and emergency medicine, and how they interlap and really improve health. We're talking today about innovative approaches within our emergency departments that are really reshaping access to treatment at a moment when we have an overdose crisis that continues to evolve. Here in Western New York, Erie County recorded at least 376 overdose deaths in 2024, following a record-setting 400 deaths in 2023. Despite a slight year-to-year decline, the crisis remains severe and underscores the urgency of coordinated and innovative solutions. Emergency medicine is when you see someone in the emergency room, and that is also the front door to addiction care here in Western New York. And as we explore how UB is leading the efforts that save lives and connect people to faster treatments and more effective treatments, I'd like you to join me in welcoming two national leaders in emergency medicine-based addiction care. Dr. Joshua Lynch, founder of Matters Network, a rapid referral and treatment linkage system that now connects emergency departments, EMS, law enforcement, and community organizations across New York State, and as of Monday, they were in New Jersey. And Dr. Brian Clemency, an expert in EMS and pre-hospital care, whose work has modernized overdose response as synthetic opioids and polysubstance use has become much more common, sadly, here in Western New York. Josh and Brian, welcome to the UB Medicine podcast. We're going to start at a really high level. You're on the front lines of this crisis every day. Sadly, the numbers are still high. How do you take these national trends and local realities and use them to shape your approach to emergency care?
Yeah, thanks for having us. We're both very glad to be here. And, I think looking at the opiate epidemic and seeing how it has evolved now over the last decade, I think one important lesson that I take with me and like to share with my colleagues is that every day looks different, and especially in the emergency department. And that looks different because people come with different backgrounds and different problems, but also the drug supply and the navigation of the system is also very dynamic. So, not becoming stagnant, making sure that we put individuals or patients first, really is kind of what keeps what my message is to my colleagues on a daily basis.
And the emergency department is a unique opportunity to engage patients and help them in their journey towards recovery, right? Some patients arrive after an overdose. Some may arrive asking for detox as their chief complaint. But many patients who are struggling with substances fall into neither of those categories. They may come in because they have an abscess associated with injectable drug use. They may come in because they have an exacerbation of their congestive heart failure, which is made worse because of overdose, or they struggle with chronic pain, which is their gateway towards addiction. And so in emergency medicine, it's so important that we are looking and casting a broad net to bring people in and support them in their recovery, no matter what door they come in or no matter what chief complaint they're presenting for.
That's it provides a holistic care when sometimes you think about the emergency room as we see on TV. It's really, as you said, a way to connect the patient to the healthcare system. And that's something that your program does so well. And we'll discuss a lot more here. But tell us a little bit about some of the drugs. Buprenorphine is now recognized nationally as best practice. How do people get those drugs now, and how does your work really make sure that they get them when they need it?
So I think it's important to start with where we were 10 years ago. 10 years ago, if you came in and you were looking for help with opiate use disorder, we would, in the emergency department, prescribe some medications like Motrin, an antiemetic, maybe clonidine for some of your symptoms. And we would give you a list of phone numbers to call for clinics that may or not still have those active phone numbers or may not take your insurance. And we would wish you the best of luck. And then we would be frustrated when that same patient came back a few weeks later with the same problem. And it wasn't a problem with the patient, it was a problem with our approach. And that approach was not unique to Buffalo. That was the way emergency departments and other care providers throughout the country were approaching patients with opioid use disorder. And Josh, why don't you speak to some of the changes that we've done to flip that script?
Yeah. So also getting access to one of the three forms of medication for addiction treatment, buprenorphine, or Suboxone is one of the trade names, naltrexone and methadone are the other two. That access has really changed, especially in the last few years. So initially, physicians had to go through 8 hours of training to be able to have an exemption to let them prescribe buprenorphine for patients that had opiate use disorder. Now, keep in mind, there was no additional training required to prescribe opioids.
So the treatment needed training, but the cause
Right.
did not.
Right. So,
Oh my goodness.
So, trying to convince our colleagues to go through 8 hours of unpaid training to get a waiver to be able to prescribe a medication was an obstacle in and of itself, but also created a stigma around buprenorphine that still is a real problem in the sense that, well, if I have to take 8 hours of training, it must be a dangerous medication to use. When in fact, it's actually an incredibly safe and very effective and life-saving medication to use. So now we've really pushed education in the emergency department to encourage our colleagues. That requirement is now gone. So anyone with a DEA certificate can prescribe buprenorphine for opioid use disorder and should.
That's excellent progress. I understand that only 1 in 12 patients receives that drug, though, after a non-fatal overdose, and the similarly are low with naloxone. How does that gap get closed?
So patients who suffer an overdose are more likely to suffer future overdoses. They're also more likely to be around people who are at risk. And so making sure that patients leave emergency departments with naloxone is an incredibly important intervention. In the last 15 years or so, we've seen the widespread adoption of naloxone in other places, right? Naloxone originally was just for doctors and paramedics, and that was it.
Right.
Now, EMTs, firefighters, police officers, but also the person who's next to you in the shopping mall or watching their kid's soccer game may have naloxone with them. We're also seeing naloxone in boxes on walls next to AEDs. And so widespread naloxone use is an incredibly important public safety measure. And it begins with us identifying the patients that are most likely to need it and most likely to be around others who could potentially need it.
Unfortunately, increasing buprenorphine access to the point that Brian just explained about naloxone access is not as easy. There's an additional barrier to get over, which is having someone prescribe it to you. The stigma around it, the fear or lack of knowledge on really how safe and effective of a medication it is a challenge that we work towards every day across the country, continuing to encourage emergency medicine and other specialties to lower the barrier to buprenorphine.
So let's shift gears just a second. The illicit drug supply has shifted, and there's increasing fentanyl involved, cocaine among fatalities. And how has the EMS and the emergency departments really evolved as we've seen this shift?
So, early in the opiate crisis, heroin was the primary opioid in circulation. And when we would take care of a patient with an opioid overdose, either in the emergency department or on the scene of a 911 call, we were relatively confident that what we were treating was heroin. That shifted to fentanyl. That created a whole kind of additional set of circumstances that we needed to be educated on and address. But now the situation is far more complicated in the sense of rarely are people just ingesting fentanyl. And even on the individual's perspective, they typically don't know what they're ingesting. So that has caused an educational shift both in the hospital and in pre-hospital care to be more mindful and more alert of polysubstance ingestions. So fentanyl contamination of other veterinary sedatives that don't respond to naloxone because they're not opioids, but also cause hypotension, and CNS depression.
Did you say veterinary? Can you unpack what you
Yeah.
just said?
So the fentanyl supply years ago started to be contaminated with xylazine, which is a veterinary sedative that causes horrific skin wounds, but also causes ongoing sedation to someone after they've received naloxone. There are other veterinary sedatives like medetomidine, which is not approved for human use, and is more of a potent veterinary sedative. So now we look to the Philadelphia and Camden area. That is typically where we see these new contaminants or novel drugs come up, and they had seen patients that were in an undifferentiated overdose. They get naloxone, and they still remain profoundly CNS depressed and hypotensive. And through public health drug checking capabilities, they were able to determine that these other drugs were at play. So now those folks require additional supportive care, typically in the hospital, where many people after an opioid overdose used to get naloxone and refuse transport. Now these folks end up needing more care from the medical system.
So when we think about these changes and we think about what is the actionable information for our EMS providers, what's the take-home message we want them to go and see their next patient with, keeping it in mind, I think it's threefold. Number one, having a low threshold for giving the patient with respiratory depression and altered mental status a dose of naloxone. Second is being prepared for escalating doses. In a time where it was a pure heroin overdose, which really just doesn't exist anymore, a single dose of naloxone and the patient would wake up, start breathing normally, and they could take the next step in care. Now we have patients who are requiring escalating doses in treatment. And then the third is real attention to airway management and ventilatory support. Some of our patients are not going to wake up immediately or at all just from the naloxone. And so making sure we're managing their airway, ventilating them appropriate, keeping their pulse ox up, so their heart is still beating and everything else is working until we can bring them into the hospital and take the next steps.
So that gets to, all the stuff that's done in the field. We're going to talk to Les Basson about the CPR program here in a couple episodes. So that's so important. I just want to hit home how you said that these drugs are contaminated with who knows what. And so, the message I want everybody to hear clearly is that none of these street drugs are safe. None. Even if they look as if they're a pill in a bottle that someone says, oh, this is Xanax or whatever. Is that right?
That's definitely right. And I think, a very specific example is we've seen patients that come in that are routine cocaine users that have presented with symptoms that they didn't understand. And it turns out that they were actually experiencing opiate withdrawal symptoms, and they had inadvertent opioid exposure through their cocaine via fentanyl contamination of the cocaine that they thought they were using. And now they have a cocaine dependence and opiate use disorder that needs to be addressed.
And patients who are taking combinations of uppers and downers are incredibly challenging to take care of, right? You can imagine someone is not breathing, you give them naloxone, you've now essentially temporarily taken care of the opiate overdose. But now there are uppers in their systems that are no longer opposed by those sedatives, right? So now the patient's heart rate's 180.
Within a matter of minutes.
Right? And so now you're trying to treat that symptom, but now all of a sudden the naloxone starts wearing off. And so you're back where you are. And so these are incredibly, incredibly challenging patients to help stabilize.
I think that this hopefully puts into perspective what we mean by the opiate epidemic has evolved.
Yes.
This is real. This is what we actually see both in the emergency department and on the scene of 911 calls.
Well, let's turn a little bit to an intervention that started here in Buffalo in 2016. And Josh, you've been leading this effort with your colleagues, and Brian. Talk about Matters. It was Buffalo Matters, then it was Matters, I think New York Matters, and now it's just Matters in multiple states.
Yeah, so we started this concept to try to help alleviate some of the conditions that Brian described about patients leaving the emergency department with a list of phone numbers that didn't work. And what we wanted to do was increase access to buprenorphine and provide immediate access or short-term access to high-quality vetted treatment organizations in the community. And there was a perception initially that there were no appointments available. So we went out to treatment organizations and asked them to care for our patients. And not surprisingly, well, maybe it was a little surprising at the time, they said sure. And we built a network with 3 treatment organizations in Buffalo and just kept going to more and more and more places, making sure that they were putting patients first, mitigating insurance issues, dealing with polysubstance use, because a larger percentage of our patient population were struggling with that, and then look to see where else can we engage patients besides the emergency department. So that turned into other environments such as inpatient units of the hospital, and as you mentioned in the introduction, the scenes of 911 calls, patients being released from jail, interacting with drug court, interacting with community outreach teams. So we built an electronic solution, a cloud-based application that almost acts as a common appointment book for several hundred treatment organizations across New York State. And as we grew and listened to our patients, we learned that they needed transportation assistance and medication assistance, which we developed voucher programs for that, and now facilitate linkage of patients across New York State in the greater Pittsburgh area. And as you mentioned, just a few days ago, launched in Camden, New Jersey with a multi-year plan to extend across the entire state of New Jersey.
So when you think about matters in the emergency department, I think the secret sauce is really how its approach meets the needs of both patients and providers. So from the patient's perspective, patients seeking care for opiate use disorder and other substance abuse are very used to being told what they're doing wrong, what they should be doing, where they should be going, and having limitations placed on them. It's incredibly empowering at 3 a.m. when I can show a patient a list of locations and dates where they can pick to continue their recovery journey.
Right then and there in the emergency room.
Right
on
then
the
and there,
iPad.
I can see you at 3 a.m. and I can say, tomorrow, there's an appointment at this clinic near your house. Would you like to go there? And if you don't want to go there for whatever reason, here's 7 other clinics to choose from.
That have already agreed to see people just like that individual.
Right.
And it doesn't matter whether they have insurance or not, or what type of insurance. You've worked all that out a priori, right?
Yeah, we've done that ahead of time.
It's great.
So that at 3 a.m, Brian in the ED in Buffalo or someone in the ED in Binghamton can present the options that are locally appropriate for that individual at clinics that have already been met with, already been vetted, and putting the patient in the driver's seat, I think, is the real game changer. Letting them pick from places that have already agreed really is not typical of their experience.
And from the physician's perspective, I can go online, I can make that referral. I have decision tools that help me figure dosing schemes out and think about what my approach is going to be. And then with a single button, I can send discharge instructions, follow-up instructions, vouchers for medications, transport information to the patient's email address. And so it's making doing the right thing for our patients actually the easier thing to do, which is incredible, right? This kind of implementation science approach is so important as we're trying to translate best practice to action for our patients.
It sounds like it is the ultimate of wraparound services for people who have, significant health challenges for access. So it's incredible, and to think that it's just from 2016, you've had such an impact. I want to just shift a little bit and talk about federal policy as we continue to shift around harm reduction strategies that we've just talked about. How can emergency departments stay adaptable while maintaining evidence-based care? And what kind of things do you think need to be changed in either federal or state policies across the country so that we continue this important work?
So if we're going to do state policy first, I'll take the low-hanging fruit is EMS providers throughout New York State are ready, willing, and able to begin buprenorphine for patients following overdose. There is a protocol in place. There are agencies who want to do this work. We are still waiting for some help from Albany to make that a reality. And so if there's anyone listening who wants to help that cause, we're ready to do that tomorrow.
It is, and this has been demonstrated for many years. With our neighbors in New Jersey, have treated many patients on scene with buprenorphine, and in probably another dozen states across the United States. And we are desperately in need of that for our patients here in New York.
Is this a prescribing thing? What's the barrier?
It's really a scope of practice,
Okay.
but only for just this one medication. So paramedics can give fentanyl on the scene to treat pain, benzodiazepines to treat seizures, but they're not allowed to give buprenorphine after an opioid overdose for someone in withdrawal. So the solution should be pretty easy. We've been working on it for years, longer than we should have had to work on this. Let's just shift to federal policy. I think what we need to talk about here is the harm reduction approach. So while we have set up pathways for people to get linked up to treatment, there are people that aren't ready for treatment, and we owe it to them to help them do things safer. And whether that is widespread distribution of naloxone, which we've already talked about, or distribution of drug testing strips so people understand and are a little bit more educated on what might be in their drug supply that they may intend on using anyway. Distributing fentanyl test strips, xylazine test strips to test for these contaminants is something that we've been doing at the Matters program now for a few years. And just a few weeks ago, we crossed the 25 million test strip distribution mark.
Say that again. You have distributed 25 million.
Over 25 million test strips across New York State. The first several million were distributed literally from the medical campus. And we're proud to partner with state agencies to be able to do that. And just a few weeks ago, we received approval to begin distribution of medetomidine and nitazene test strips, which are two emerging additional very dangerous contaminants that are popping up in the drug supply across New York State and across the country.
And these test strips are so critically important for empowering our patients and helping them make choices to minimize the potential harm. And there's a number of different ways they can receive test strips: mail, through Matters partners. And I think the really exciting option is through harm reduction vending machines that we are now seeing more and more of throughout New York State. And so we are really trying to get resources to patients where they are. And I think the Matters Network and the vending machines are a really exciting way to do that. How many vending machines do you guys have out now?
There's 42 all centrally connected, internet connected, temperature controlled vending machines across New York State. And we actually just put out 2 papers on that back in November of 2025. And we also intend on installing about 24 or so vending machines in New Jersey. So that will be a great source of data for us to better understand kind of utilization of these machines, what that looks like, and learn from that and then adapt.
And we've got 2 great papers he alluded to with our colleagues from Family Medicine, taking a look at, how did we implement these across New York State? Doing the first or the second one is very challenging. And after you've done the 30th, 35th, and 40th one, it gets a little bit easier. And so we've worked out a number of those kinks. And hopefully those papers provide a roadmap for others in other states who are trying to think about implementing vending machines for harm reduction.
Well, you both have made such a difference, and this has been just a really enlightening discussion, and I really want to thank you both. Before we go, I just want to get one key takeaway, 1 to 2 sentences about your hope for the future of improving health in Western New York.
Yeah, I think on the addiction note, we all at this point likely know someone struggling with addiction. And I think the most important takeaway there is this is not an easily solvable problem for most people, and it's not a quick fix. So what we hear from patients and care providers is that those individuals really need people to stick with them and understand that it may take 3 or 4 or 10 tries to get through. So whether you're their healthcare professional caring for them or a family member or a colleague that's supporting them, sticking with them and learning kind of the challenges that they may be facing is very important and much appreciated by the patient.
I think as physicians, we like to think that we're the solution, and we're often only a tiny piece of it. And I think to really give patients who are struggling with substance abuse disorder the best support and the best chance, we need lots of wraparound services that go beyond what we do as physicians. Transportation vouchers, assistance with medications. There's such incredible support with peer programs that we're I think we're only really tapping the surface of how incredibly impactful peer support can be and part of recovery. And so while we need to keep focusing on Suboxone and those interventions, keeping our eye on the prize of these other non-physician services are so critically important is the key.
Yeah, that's so well said. Well, I just want to thank you both, Dr. Lynch and Dr. Clemency. You've made such a difference here in our region and now across multiple states. I want to thank you for sharing your expertise today with our listeners. And to our listeners, I want to thank you for joining us. I'm Dr. Allison Brashear, and this is the UB Medicine Podcast. We look forward to continuing conversations about innovation, discovery, and the future of healthcare in Western New York. Thank you again for joining us, and we hope to see you again next time.